Friends, welcome to my workplace at Ranaghat, West Bengal, India. This is an intumescent cataract. In this video, I want to show an ideal Rhexis and the CAROUSEL technique for nucleus management. The main incision has been placed, and now a side port is made on the right side of the main incision, about 3 clock hours away, and one more side port is being made on the left side of the main incision, about 2.5 clock hours away. In intumescent cataracts, I always make 2 side ports, and I use the right side port for the initial C flap. An air bubble has been injected into the anterior chamber, and now trypan blue dye is applied over the anterior capsule underneath this air bubble. The dye should touch all parts of the anterior capsule. Now, after a few seconds, the dye is washed out. There is no need to wait more than 10 seconds. If we wash the dye out, the incidence of TAS reduces. And now the anterior chamber is filled up with 2% HPMC, hydroxypropyl methyl cellulose. Yes, in intumescent cataracts, I always use hydroxypropyl methyl cellulose. And now Capsulorhexis. The anticapsule is incised and a C flap is made with the help of the 26 case bend needle. Now a utrata forceps is used to convert this C flap into a mini Rhexis. Without having a mini Rhexis, we should not try aspirating cortical lens matter. The mini Rhexis can bear the pressure of the Simcoe or bimanual IA if you are using that. But if it is not a mini Rhexis, just a C flap, just by the pressure of the Simcoe or bimanual IA, the tear will run to periphery. Now, as some cortical lens matter is removed, the intralenticular pressure reduces drastically, and we can easily enlarge this mini Rhexis into an adequate sized Rhexis. HPMC is injected again, and now a Vanna scissor is taken. A nick is made at the margin of the mini Rhexis. The utrata forceps is taken again, and the Rhexis is enlarged to an optimum sized Rhexis. In this case, I found that the capsule from 1 o'clock to 3 o'clock is more. So I come there again. You can call this spiraling, and do a Rhexis of ideal size. If we can do Rhexis of this quality, do we need a femtolaser? Probably not. So if we can raise our scales to a certain level, the necessity of a femtolaser decreases. Now watch the CAROUSEL technique of nucleus management. The phaco needle has been placed at on o'clock facing the lens mass. The chopper is supporting the superior surface of the lens. By simultaneous application of vacuum and ultrasonic energy, the nucleus is managed. And these are the small bits of nucleus. These are being taken out. One more piece near the side port, it is also removed. So this has been a very satisfactory use of carousel technique. In this case, the nucleus was very soft. If we try to chop this kind of nuclei, we may land up in piercing through it and go through the posterior capsule. In this case, I am going to use a B cartridge. That's why I enlarge the main wound. And now I am using a 23 gauge Simcoe to remove most of the cortex except the sub-incisional part. My assistant is getting ready with the bimanual irrigation aspiration at this moment. And now I take the bimanual irrigation aspiration. There is some cortex at 7 o'clock also. And now I use the irrigating probe to hydropolish the posterior capsule and dislodge the cells from the posterior capsule. And now the irrigating probe is introduced to the right side port, aspiration through the left, and rest of the cortex is removed by this bimanual irrigation aspiration system. There are a lot of air bubbles on the corneal endothelium. And now hydrophilic acrylic single piece monofocal intraocular lens is being implanted in the capsular bag. The leading haptic goes into the capsular bag and the trailing haptic is pushed into the capsular bag by the irrigating probe. At this time, the irrigating probe is removing the visco that was in the lumen of the cartridge. And now see the optic of the intraocular lens is covered all around by the Rhexis margin, and this means the Rhexis is adequate and ideal. So the side ports are closed and a final lavage of the anterior chamber is done. A gentle stream is directed towards the corneal endothelium at this time. Care is taken that the stream directed towards the corneal endothelium should not be very forceful. One or two speck of cortex was there, it was removed, and now the antechamber is nicely formed. Intraocular pressure is kept on the higher side and integrity of the wounds are checked. There is no leakage from any side and the case is concluded. Thank you very much for your attention. Hope this video will help you in developing your surgical skills. Be a great surgeon and serve your patients with love, respect, empathy, and great surgical competence.